name is Rachel, and I am the site engagement coordinator with MVC, one of the site engagement coordinators. I'll be facilitating this preoperative testing work group today, and it'll be my pleasure to do so. Just a few housekeeping notes, just so that you're aware, this session is going to be recorded. The slides and the recording will be made available to you following the conclusion of the work group. Also, we will be holding questions until the conclusion of the presentations, but please feel free to add any questions that you might have to the chat throughout the presentation. And then lastly, your feedback is very important to us. We will be providing a survey link at the end of the work group. This is the post-work group survey, and we'd really appreciate your feedback. And then also just a reminder for any hospitals participating in P4P, this post-work group survey is actually mandatory to receive the credit for your engagement points. So don't forget to fill that out. Today we are going to be hearing presentations from Pamela Racchi and Susanna Fortney. Pamela joined the Michigan Surgical Quality Collaborative in 2020 as a clinical site coordinator. She is a registered nurse with clinical experience in critical care setting. She also transitioned into healthcare quality, where she spent the majority of her career. She was previously in healthcare quality positions in acute care settings, managed care, and quality improvement organization settings. She has earned an ADN from Schoolcraft College and a BSN from Madonna University, and she also maintains a certified professional in healthcare quality certification. Susanna earned her Bachelor of Nursing from Ohio University in Athens, Ohio. She has practiced nursing for over 30 years in a variety of areas, including perioperative nursing, care navigation, utilization management, and quality. Susanna has been in her current role as a clinical quality specialist and MSQC SCQR for 2.5 years. With that, I will pass the torch to Pamela, and she will begin her presentation.
All right, thank you so much, Rachel. Let me get my slides pulled up here. Okay. Thank you for that introduction. And what I wanted to do today is kind of give the audience an overview of the Michigan Surgical Quality Collaborative's preoperative testing project. And that has been a collaboration with Michigan Value Collaborative as well. And kind of give you an idea of where the project stands as of now and how we've been progressing. So the project basis for us is similar to what Michigan Value Collaborative has done with their project. We really wanted to define the extent of routine preoperative testing in low-risk surgeries and identify the underlying reasons for overuse of preoperative testing in surgeries that are low risk. We know there's variation amongst hospitals, and we're having our sites implement interventions that help heighten awareness in the provider arena and also to try and reduce that variation amongst hospitals. This is a continuation of the pilot project that we started in 2023. That was our first year for the project. We learned a lot during that pilot year, and we have incorporated what we have learned during 2023 into the project for this year. The project eligibility is a little bit different from Michigan Value Collaborative. We are only looking at low-risk procedures, but our procedure grouping is just a little bit broader than Michigan Value Collaborative. In addition to inguinal and femoral hernia repairs, we're also looking at abdominal hernias that are less than 3 centimeters. We also include the laparoscopic cholecystectomy and breast lumpectomy, just like MVC. For this year, we're looking only at ASA classes 1 and 2. Last year during the pilot, we did not exclude any ASA classes. And some of the feedback that we heard from our sites was that they felt patients who are ASA class 3 or 4 are a little bit higher risk because they have ongoing medical issues, they have chronic conditions that would warrant testing much more frequently than the lower ASA classes. So we went ahead and limited this year just to ASA class 1 and 2. And when we do that, that really makes it, I want to say, more difficult to get pushback on not testing those ASA classes, because these patients are much healthier, pretty much straightforward, very stable. So they're the perfect group to eliminate that unnecessary preoperative testing. We're also only looking at elective cases. That is something that our abstractors capture when they review the record. So we're able to remove any emergent hernia repairs or emergent cholecystectomies from the mix. So we have a nice tight group of patients and procedures that we're looking at. And we're also only including the case if it's the intended primary procedure. So if the patient went in for, say, a colon resection, that was a primary procedure, but they also happen to repair a small incisional hernia, those patients are not included. So what we've tried to do is really tighten up who is included in that procedure cohort, so that eliminates some of that conflict that can happen in terms of what's really clinically indicated for preoperative testing. So what I've done is pull together some data from this year, and these are cases that our abstractors have reviewed as of the end of September. And just to give you a little perspective on that, the end of September is a date that means the case was abstracted. However, our abstractors are looking at cases about 30 to 60 days out from the operative date. So in September, our abstractors are most likely reviewing July, maybe some August cases. So when we're looking at this preliminary data, we know that this is a lower is better measure. That's where we want to see that trend go. What I did was break this down by both different ASA classes. When they get scored, it will be collectively all ASA classes grouped together, which is what you're going to see on the far right of the graph. And the blue bar is the baseline rate, where the project started out as a whole across all of our participating sites. And the 20% relative reduction goal that we ask, which is based on the baseline rate, we wanted to get them down to 32%. And as you can see by the green dotted line on there, that they're actually doing much better than that. The yellow bar for the measurement rate is actually below that green bar, which is a good thing. The lower it is from the green bar, the more reduction in unnecessary testing is happening. And when I broke that down by ASA class, we're doing as well there. You can see that ASA class 1, they've really made significant impact there. And really, if you think about it, that's the group that's most important, or that's the really low-hanging fruit, right? Those are the cases where this patient is healthy, they don't have chronic conditions, they don't have anything unstable happening medically. So these patients, it begs the question, Are we doing preoperative testing on them, and why? Do they really need that testing to be done? And then ASA class 2, a lot of those patients are also stable with their comorbid conditions, so it's not unexpected that we should be able to reduce unnecessary pre-op testing there. And just like the other ASA groupings on the graph, you can see that the yellow bar is actually lower than that reduction goal that we had of 32%. So for really across the board, even though it's early days in the project, we still have several more months in the year, things are trending well. There's still opportunity to lower those rates even more, as I had just mentioned about, especially ASA class 1, with those are, the healthy younger population, no pre-existing conditions. Those are patients where if you're seeing a lot of testing still done in those ASA groups, that's where you can make some impact, have discussions with your surgeons and your anesthesiologist to see if that testing is even necessary. Another thing that we asked our sites to do is to also look at cases where preoperative testing was done on the day of surgery prior to them going into the operative suite. So the preoperative testing rate in general, what the data that we just looked at, is based on any preoperative tests that are done on preoperative days 1 through preoperative day 30. So we use that date range so that we are mirroring how Michigan Value Collaborative is measuring their preoperative testing rate as well. We're both using days 1 through 30. And from a Michigan Value Collaborative standpoint, that makes perfect sense because their data reports are being based on claims. And when you have a claim, although you have a data service, you don't have a time of day. So you might see that there is, say, an EKG that's done on the day of surgery, but the question is, on the claim is, well, was it done before surgery? Was it done after surgery? You don't know. So that makes sense as to why they're eliminating the day of surgery and testing on that morning. However, when we abstract the chart, our abstractors have always captured the patient in-room time, which is when they're wheeled back into that operative suite. So our abstractors are able to look at the date and time stamp on the preoperative test, and they can tell if it's done prior to surgery. So what we wanted to do as well with our project is to also have them look at any of that testing that occurs on the morning of surgery. In fact, what we did was, with the goal for the project, the goal is to reduce the rate of preoperative testing by 20% as compared to baseline without an increase in preoperative testing on the day of surgery. So what we don't want to see is that, oh, you're making strides. Wow, look at this, your preoperative testing rate is going down, but oh, wait a minute, your day of surgery testing rate is going up. So what's really happening here? So one of the things that the abstractors need to do for their project this year is to perform an analysis on the cases that did receive testing on the day of surgery prior to in-room time. We're asking them to look at a little bit deeper in the medical record on those cases to see if they can figure out why it was done on the morning of surgery. If the patient has sudden onset chest pain, or they put them on the monitor and pre-op holding and notice, oh my gosh, all of a sudden they're in atrial fib and they don't have a history of this, makes perfect sense to be doing an EKG and maybe some other preoperative tests. But that should be reflected in the medical record. So that's why we're having them dig a little bit deeper and do an analysis on all those cases, and then look for trends that may be occurring and address those trends as necessary. And then when they submit their annual project summary to us, they will include their findings from that deep dive. So here what I have is some day of surgery preoperative testing data. And what you can see is the baseline, which is the blue bar, is a little bit to somewhat lower than the measurement rate right now. So although we saw really good trends on the last graph that I showed you, which was the preoperative testing rate, now what we need to do is figure out why we're having a rise in testing on the day of surgery. So hopefully those deep dives that the abstractors are doing will shed some light on whether these were actually clinically justified tests or if it was just physician habit because the physician saw on the morning of surgery that the patient didn't have a CBC or didn't have a metabolic profile, so they went ahead and ordered it on the morning of surgery. So some success factors that we've heard from our participating sites with the project, the first and probably the foremost is that there has to be collaboration between surgery and anesthesiology. That is probably the only way we're going to be able to streamline the preoperative testing process and decide on a protocol that really makes sense. Because we know that preoperative testing can happen in locations other than the hospital, other than a preoperative testing clinic. Some sites are small and they may not even have a pre-op testing clinic. So that preoperative clearance may be done in the surgeon's office. It could be done in the PCP's office. So it's really a matter of the quality team knowing where preoperative clearance and preoperative testing can potentially be ordered and making sure that those locations are included in your project implementation and that they know what that new protocol is, what's on there and what's appropriate for testing and what things should be avoided. And as I mentioned earlier, performing analysis on cases that receive testing on the day of surgery prior to in-room time, that is also very important in knowing whether that testing was justified or whether it was ordered out of habit. But there are challenges with the project as well. And some things that we've heard are that there might be multiple versions of older protocols that are still posted. Say they're still posted on the preoperative clinic nurse's clipboard, and that's what they're used to using, or it's still posted next to the computer and in the physician's office where they order their labs. So it's really a matter of kind of doing a hunt and trying to purge those old protocols and making sure that everyone understands what the new protocol is and making it readily available. Physician practice preference, that has been a struggle. With some sites, they've been able to sail through and everyone's on board. And at some other sites, they're having physicians say, but wait a minute, I've always done it this way. I really want to make sure that I cover all the bases, that I've looked at everything. So a lot of that is a little bit of push and pull. And in those situations, that's really where you need your physician champion leaders to kind of take the bull by the horn and have discussions with those providers and come to a consensus on how they want to proceed. We've also heard that there's been testing on the morning of surgery because they wanted to, quote, save the patient a trip to the hospital just for the labs. So the labs are still getting done, but they're being done on the morning of surgery. But it also begs the question of, but are the labs even necessary? Because these patients that we're focusing on are in the lower ASA classes of 1 and 2. And as I had mentioned before, multiple locations for preoperative screening. Some sites don't necessarily have a dedicated pre-admission testing clinic where all the patients are seen prior to surgery. So reaching out and finding those locations, that's like a task in and of itself, but it's knowing that you have those external possibilities that could impact your rates. So with that, that's all I have, but I am going to hand it off to Susanna Fortney from ProMedica Hickman, and she is going to share her experiences at her facility with this project. Thank you.
Thank you, Pam. Did I share the right screen? I think I did.
Yep, you're good.
Well, thank you everyone for having me. I work at ProMedica Hickman Hospital. We're a rural hospital in Adrian, Michigan. Our hospital in 2024 did the pre-op testing project for MSQC, and we also were one of the three hospitals that participated in the right size pilot site. So I just wanted to share a little bit of our timeline and experience, and also a little bit about being a right size pilot site, in case there's anyone out there that was offered to be a pilot in this upcoming year and isn't sure what to expect. So I created a timeline here, not 100% inclusive, but I did just want to point out our story here. So I'm going to jump back. That's not on my screen. Back in 21, 22, we were sharing MVC data at the surgery committee meetings, and we were one of the higher hospitals that ordered quite a bit of testing. So we started the conversation back then. And just from having the conversation and anesthesia being motivated and making some small changes, we actually were able to make a decrease in our testing. It was approximately 20% from 21-22 to 2022-23. So that was encouraging. In 23 for MSQC, we actually elected a different project, but knowing we still had a high amount of testing, we utilized the tools that MSQC offered through it's called Right Size now. It was previously called Wave the Workup when we utilized some of those tools in 23. So 24 came along and we decided to participate in the pre-op testing project. So this is kind of where my slide starts here. So we already had made some changes to our anesthesia protocols in 23. So we already had developed and adapted the protocol, had our kickoff meeting through MSQC. And then we added a decision aid in May. And throughout this process, pre-admission testing and the team was educated in May. And I'll speak a little bit more detail on the rest of these steps here, but I just wanted to share kind of what our year looked like percentage-wise in testing. So in January, we started out our baseline. Sorry. Our baseline was 46.15 for the measurement period, and our goal was 36.92% or less, and we are currently at 30.77%. So we are on track for meeting our goal. And this blue star up here for review of fallout cases, I'm going to elaborate on that. So what we found with that timeline on the prior page was that even after we implemented our tools, we were still seeing fallout cases. So we took these cases and took a deeper dive into them and took a look at what we could change. So the green area, 37%, were cases that we found to be justified. The surgeon or primary care or whichever provider actually documented a reason why they ordered the test, or it was a clear reason. For example, someone that has symptoms of urinary retention and could have a UTI would need to have a UA done. And then what we focused on was the yellow and blue areas here. So the biggest area was anesthesia protocol use and interpretation. And I just want to briefly speak about the ASA class as well, because what we found is that the ASA class, it is recommendation through the tools that we have, but the ASA class didn't always match our decision aid or our anesthesia protocol. So that was kind of a area that I deferred over to our anesthesia, chief of anesthesia. So this is a snip of our anesthesia protocol that we have. So we have, we actually ended up embedding our decision aid into the anesthesia protocol. And that helped for a better visual when in our department, in our hospital, I should back up and say that our pre-admission testing, we don't have a nurse practitioner or anyone there that actually does the HMPs and would be able to assign ASA class. So the HMPs are done by our surgeons in their offices when they see the patients. So we had to kind of adjust the decision aid that was provided by the right size and make it more, we had to make it fit. So the nurses weren't assigning ASA, but we kind of captured what that ASA 3 class would look like. And that would be the far right green box there. So if a patient fell into those categories, not all inclusive, of course, but then they would move on to the anesthesia protocol. But right in our protocol, we actually put specifically for a breast lumpectomy, laparoscopic cholecystectomy, and hernia repair that these patients would need to be evaluated based on the decision aid. So our next step was for the ASA classes. What I did is tracked when the ASA class didn't match. For example, this patient had a BMI of 50, had some extensive cardiac disease, diabetes, and a high A1C. So this patient, according to our guidelines, wouldn't fall in the category of ASA2, and yet it was classified ASA2 by the anesthesia provider. So when I had cases like this, I just kept track of them and shared them with the anesthesia, the chief of anesthesia, our champion for the project, and he did follow up with the anesthesia team. So I gladly gave that piece to him. But our biggest finding was with the pre-admission testing nurses. So when we did the investigation of the cases, we actually broke it down to look at who ordered it and why they ordered it. So all along we were tracking who ordered it, just kind of broadly, like this is anesthesia ordered this, PCP ordered this, or the surgeon. And what we did was we zoned in on who specifically ordered it. So what we found is in our pre-admission testing department, we had 2 nurses that were ordering the most testing. And when we matched it up to our protocol and decision aid, it did not, it was inappropriately ordered. So what we did is we met with the nurses one at a time and just talked to them and made sure to see what their understanding was and what concerns they had or what they didn't understand. And what we found was one of the nurses shared that she just has been doing pre-admission testing for so long that it was difficult to kind of change gears and not include those cases in testing. And then one of the other nurses was newer and just was unfamiliar and just kept forgetting to use it. So when we embedded the decision aid, we had it separately when we first created that, but when we embedded the decision aid, that made a difference because they were had to stop there and have a better visual. And in addition to having the decision aid there, we also created these little visual reminders, and this was these illustrations are actually from the Right Size pilot team. So credit to them for that. But I did print these and laminate these just as a reminder to to the nurses, excuse me, if you have one of these, stop and look at the decision aid. And that actually did make a big difference in what we were seeing for testing, and had some positive feedback, just such a simple piece there. The other thing we did is we created case studies. So we took a lot of the cases that did have the inappropriate testing and actually created just a simplified kind of case study, gave it to the nurses along with the protocol and decision aid, and asked them what they would order. And it was just an open conversation, and it was just a really good review and experience, and definitely positive feedback on that as well. The other thing we did is we weren't initially sharing reports with the pre-admission testing nurses with the entire department. We pulled one of the nurses to be the lead, who did participate in the pilot site and our meetings, but it made a big difference when the nurses actually were included and received the reports and gave positive feedback when they were able to see moving in the right direction with the last two reports. So those were our big successes that made a difference. And that's actually the end of my slides. Thank you.
Awesome. Thank you, Susanna. So now we're going to be opening it up to questions and discussion. So if anybody has a question, feel free to raise your hand or just speak up, and we'd be happy to hopefully answer.
While some folks are finding their unmute button there, I actually have a question for the group. I do know that Pam, you had invited some of the data abstractors from MSQC are on this call, and we have our usual quality lead folks on here. You mentioned a couple of different changes to the program in the coming, or to the way that things are set up coming up. And I'm curious if folks can find how to raise their hands here, which sometimes I struggle with that. That's why I say it like that. But if I could see like a show of hands of those who are more on the quality lead side that were aware that these changes were coming. I know your data abstractors, hear this information from you guys, but we often hear that the ability to be able to kind of cross that information over across the team can be a little bit challenging.
Yeah, so one thing that we've done with the project for next year, for 2025, can't believe that's almost here, but we did release all of the project options that our sites can select from for next year. They have 6 different QI projects that are available to them. And one of the projects, of course, is going to be a continuation of the preoperative testing project. Now, one difference with the project is that it's only open to invitation. And that invitation was extended based on the fact that, first of all, they had to have participated in a previous year. So they're either participating this year or they participated in 2023. We did that because for both of those project years, we have a solid time frame for baseline data. We have a full 9-month time period to calculate your baseline. And that's so much more representative than when you are a new site and we can only base it on the first 3 months of the year, say from January through March. The other criteria that the invitations were based on was the actual measurement rate that the site has, and it's their most recent measurement rate. So obviously for the sites that are participating this year, it's their most current report that they receive monthly from us. And then for sites who participated last year, we are using their final measurement score from the entire measurement period, which was April through December of 2023. What we wanted was for those sites to have a rate of at least 20% preoperative testing in the ASA classes of 1 and 2. When the number starts getting lower than that, when you're doing really well and your preoperative testing rate is 12%, 10%, it's going to be really, really hard for those sites to be able to move the needle even further. And that's because there's always going to be a scenario where the preoperative testing was appropriate.
Right.
So we don't want to make the goal 0 because that doesn't make sense. But we want to have enough breathing room in there for these clinical scenarios to be accounted for in a reasonable fashion. So we did not extend the invitation to sites that have a relatively low rate because we just knew it would be too difficult for them to be successful when they're already probably about as successful as they're going to be with it.
Yeah. Can I ask, those reports, those monthly reports, how do you guys distribute those? Do those go out directly via email? Do you have a Dropbox system? Here at MVC, we use Dropbox. I'm just curious how folks can get those reports.
Yeah, we use Dropbox as well.
Okay.
So our analysts, they wait until the day after the month closes.
Okay.
And then we get a data download from our registry vendor. Then the abstractor or the analyst will use that data dump and then calculate the rates. In fact, they just got one late last week.
Okay. Yeah. Great. That's good to know. Thank you.
Oh, and let me just mention one other change for next year. For this year, I talked about how they need to be able to do a deep dive into all those cases where the testing was done on the day of surgery. What we're doing for next year is we've actually created a measure for day of surgery testing. What we're doing is defining it as for any test that is for any patient who has one or more tests done on the day of surgery, there needs to be clinical documentation in the medical record to justify why that testing was done. And the rate of justified testing needs to be at least 90%. So now we've actually put a goal around that, and the site will earn points if they are able to keep that clinically justifiable testing at 90% or higher. But if they're still struggling with some physicians that are just doing it out of habit and just do it on the day of surgery because when they look at the chart that morning, the patient doesn't have any tests, that's going to be a real barrier to try and manage.
And the decision aid that Susanna shared with us, it looks like that helps to make it a lot more easy for folks to kind of comply with the documentation of the clinical need for the testing. Is there anybody that's on the call right now that could kind of talk a little bit about maybe how you've been able to do that or thinking about doing that? Because I think, Susanna, you shared a great example with us, but I know there's multiple different ways to accomplish this. No?
I can just add that I know that the decision aid that's provided by the on the right size site actually lists it out by ASA class. So I wonder if some of the hospitals that actually have someone doing HMPs in pre-admission testing maybe adapted that without having to change it as much.
That's a great point. Thank you.
I actually have a question for Susanna. And I don't know, maybe, I know you mentioned the fallout case review earlier in your presentation, but I was just wondering if you could tell me a little bit about the people or the roles that were involved with the review process. And if there were any people in particular that you wish could have been a part of it, but weren't a part of the review process of those cases.
Sure. So, what I did is I actually did the initial review and then I shared it with our team. So, our team included our surgeon champion, we had an anesthesia champion, and we had our MVC representative on site here at ProMedica, and we also had one of our lead nurse from pre-admission testing, and myself. And we reviewed these cases. And the other thing that I want to mention is when we were tracking these all along by grouping, like I had mentioned, and it was the pilot site team that kind of gave me that extra push and said, "Why don't you take a look?" Because I was looking at PCP orders or orders outside of anesthesia to justify why they were ordering. But when I actually looked at the anesthesia, the ones that were being ordered by anesthesia, and could identify that it was more related to nurse, that made a big difference. And that kind of rerouted us on what we needed to do to make changes and provide additional education.
Awesome. Okay. Thank you.
And I don't, our hospital's small, so I think that the group that we had was ideal for these reviews. For our setting, I can't think of anyone else. I also did have a surgeon. I think I mentioned a surgeon. Our surgeon champion was there, but I think that our group was just the right size.
Perfect. Okay. Thank you. Did anybody have any questions following up on that discussion? Or any comments, or anybody want to share their experience with their own program? Alright. Well, if everybody is content, we will move on with some updates here. Give me 1 second to share.
Can we have these slides sent to us, the slide decks?
Yeah, absolutely.
Okay.
We'll be sharing the slides and then also the recording as well.
Okay, thank you.
No problem. Okay, so just need to. Hurry, hold on a second. My Windows got all weird on me. Okay. Let me share this one. And I want to switch. Okay, I think I got it. Hold on 1 second, guys.
We've all been there, Rachel.
Can you see the slides? And not.
We have the notes view.
Ugh, of course you do. Okay, hold on.
Okay.
Okay, is that good?
You're good.
Okay. All right. So let me get to the right slide. Oh my gosh. I had this on the right slide and then I just hopped to the wrong slide. There we go. Okay. Seriously? All right, bear with me, guys. Sorry.
Okay. We get a second view of the slides.
Yeah. Okay. All right. So just want to kind of give you all a heads up on our upcoming work groups. The next one will be our last cardiac rehab work group on November 21st, which is a Thursday. And then following that will be our last post-discharge follow-up on December 3rd. And then our last rural health work group on December 12th. And just a reminder that all of these work groups occur virtually from 12 o'clock to 1 o'clock. Let's see, moving on to the next slide. Additionally, we have a few other items of interest. We have a couple of P4P selection webinars coming up. These are put in place to allow Anyone who wants some assistance or wants some guidance on choosing their P4P selections for this upcoming 2026 to 2027 year, they can join these webinars. We'll be doing a presentation and then having like an open question discussion time to answer any questions. So the first one will be November 19th, which is a Tuesday from 1 to 1:45 p.m. And then the second will be on November 21st from 10 a.m. to 10:45. Additionally, we will also offer some one-to-one P4P selection assistance if needed. And we will be providing the links for all of these in the email that will follow the work group. And then just a heads up that we will have preoperative testing registry reports coming soon, hopefully by the end of this month. We will drop the link. I think Emily's going to help me with that in the chat for you all who completed the work group today. Please be sure to fill out the survey that the link takes you to receive your P4P engagement points. With that, I'm going to conclude the work group session. Thank you so much for attending, and we hope to see you all in the near future. And have a great rest of your day.